Good evening, everyone. I'm Robert Margo. I'm the chair of the Department of Economics at Boston University. I want to welcome you to our event this evening, Solving the Healthcare Reform Puzzle, How to Balance Cost, Access, and Quality. So this is the academic year's first Discoveries program. Discoveries is a learning and lecture series that we have at BU that features the truly widespread and great teaching that we have at BU. And it allows our attendees tonight to hear programs like this, which focus on, among other things, the great policy issues of the day, and certainly there's not too many that are greater than healthcare reform. Discoveries is one of the cornerstones of BU's philosophy of extending the learning community to alumni and making this university a home for all of you throughout your lives. I'm supposed to remind you that this is not the only event we have this year. Our next event will be on November 19th, and it will be a panel discussion on something very different, on cyber terrorism and warfare. The next bullet point, I'm sure, is here because I've just become the chair of the economics department. I've only been the chair for a month, and the development office wants to give me practice. So the next bullet point is, so much of what we do here at Boston University is made possible by the generous alumni, parents, and friends that support our alumni, our annual fund, and encourage you to participate. You can find information on giving at the sign-in table, and Julianne Grant from the Development Office would certainly be happy to speak with you. My final task now is to introduce one of the speakers tonight and the moderator of the panel, my colleague and good friend Randy Ellis. Randy is a professor of economics and the associate chair of the economics department at Boston University, and he's been a member of the faculty here at BU since 1981. He earned his degrees in economics from Yale University and the London School of Economics before getting his PhD from across the river at MIT. He is one of the world's great health economists. His work spans the United States and the rest of the world and many developing countries as well. He is the president-elect of the American Society of Health Economists. He's also founded Verisk Health, which is a healthcare information and consulting firm that examines risk adjustment models and predictive modeling. And I should say he's a truly dedicated teacher of undergraduates and graduates alike, one of the very best advisors that we have at BU. And if for some reason he were not the associate chair of the economics department, we would have a healthcare crisis because I would have a heart attack. Randy Ellis.
Thank you, Bob, for your kind introduction. It's a pleasure to be here tonight, and I'd like especially to welcome all of the alumni, colleagues, and friends here who came out for this panel discussion. We're also delighted that WBUR has joined us to record this program this evening for the possible rebroadcast on Sunday on the evening radio program World of Ideas. At this possible inflection point in the United States healthcare reform debate, it's an honor to introduce tonight's panel of leading experts on the healthcare issues. The panel comes from 4 different disciplines in 4 different schools at Boston University. In addition to myself, an economist, we have a management expert, a mathematician, and a legal scholar. What a wonderful signal of the breadth of knowledge and interest here at Boston University and the strength of the health field that cuts across many of our schools and colleges. With most academic presentations I give, I have to spend a few minutes motivating the topic to make sure people understand why it's important. I don't think I'll have to waste your time with that tonight. The Senate Finance Committee has already released a great many of the details of the primary proposal for healthcare reform. And remarkably, just today, the Congressional Budget Office has released its evaluation of the cost impact of that likely form of the proposal. And so we have a lot of information available, although it still has to go through a committee that will be trying to hammer out the differences, the important differences between the Senate and House bills. But I think that one comment is that we're academics here, and most of us are doing research on very specific topics, and it will be important for us to share the knowledge of the things that we do know about, and hopefully we won't get embroiled in the political controversy of who said what, and is that really what you meant. I will say we don't know the nature of the final bill that will be voted on, but we do have a lot of indications of the dimensions on which the debate will be centered. And it's impossible for any of us not to take an interest in how it ends up, no matter how we feel about the current bill. I'd like to now introduce the three panelists at one time, so they won't have to stand up again to reintroduce them between their comments. In alphabetical order, the first speaker is Dr. Arlene Ash, who is received her doctorate in mathematics from the University of Illinois, Chicago, and has been a research professor of medicine and public health at Boston University's School of Medicine and Public Health for many years. A biostatistician, she heads the Healthcare Research Unit in the section of General Internal Medicine. This month, she starts a new position at the University of Massachusetts in Worcester, although I'm pleased to report that several of her collaborations with BU will continue. Arlene is a longtime advocate for providing equally good care to individuals who differ in race, gender, age, and disease, and she's probably best known for her collaborative work for the U.S. Medicare program, developing payment models that reimburse health plans and provide more value when they care for sicker patients. And this work is accomplished using risk adjustment. Professor Ash is a fellow of the Academy Health, as well as the American Statistical Association, and her current research is divided up among so many topics I can't try to list, let alone discuss them now. But two of them are on racial disparities in healthcare services for Medicare beneficiaries and alternative payment systems for primary care practices. I'm a longtime collaborator and friend of Arlene's, but I will try to not let this get in the way of my allocation of time and questions I ask her about. The next person who will be introduced is Stephen Davidson of the School of Management. He's a professor of healthcare management and policy and former director of the school's healthcare management program. Steve's written on many topics, but he's probably best known for his work on how physicians and health plans can work together to provide effective health care. He's also written on how insurance affects healthcare decisions, both from the consumer and the purchaser's perspective. Perhaps inspired by knowing that this is the year to influence national healthcare reform, Steve put on hold his other research and has just written a book, now forthcoming, called In Urgent Need of Reform, Saving the U.S. Healthcare System. And some of you may have seen his interview on the BU Today, which came out over the summer, and you can all look for his interview that will be in the Boston University Alumni magazine, Bostonia. In his free time, I assume he has some, Professor Davidson has recently been writing for the Huffington Post blog, and he's going to share where he shared some of the ideas he'll talk about tonight. And like Arlene Ash, Steve once resided in the Windy City, and he earned his doctorate at the University of Chicago. He's also a longtime friend. He used to live 5 houses down the street from where I live. The third panelist, Gary Young, earned a law degree and doctorate from the State University of New York and is now a professor and chairman of the Department of Health Policy and Management in the Boston University School of Public Health. He's also an associate director of the Boston University-affiliated Center for Organization, Leadership, and Management Research of the Department of Veterans Affairs. Gary's research and publications focus on organizational, managerial, and legal issues associated with the delivery of healthcare services. And he's particularly known for his work on promoting quality and measuring outcomes at the hospitals and encouraging teamwork among the staff and also taking patient satisfaction seriously into account. Before coming to becoming a professor at Boston University, Professor Young worked in both the private sector and for several federal agencies, including a stint in the U.S. Department of Health and Human Services. Any academic has to respect the real-world experience that implies. I'd also like to welcome members of Professor Young's family who are apparently attending tonight. So, although we chose a title for tonight that suggests we may actually be solving the healthcare reform puzzle, actually our goal is much more modest. I'm sure that you will find our panelists to be experts in the areas of their combinations of health insurance, pricing, incentives, quality, and costs. And hopefully, without resorting to name-calling or political positioning, we'll all be able to leave tonight with a better understanding of what some of the challenges are and what some of the possible solutions are. The structure of the program is that I'll give each of the participants about 10 minutes to talk about their own area of knowledge, and then I will follow up with a few questions to each of them. And after that, we'll open the floor to questions from the audience. I would like to remind you that because this is being recorded, I encourage you to receive one of the microphones that will be handed out before you speak so that we can all hear and understand what the question will be. And by mutual agreement of the three panelists, Steve Davidson will be going first, followed by Arlene Ash, and then Gary Young. Thank you.
Thank you, Randy. It's a pleasure to be here and to talk about healthcare reform, a topic that's important to all of us. And as Randy indicated, I recently completed a book about healthcare reform. So what I plan to do is to talk for a few minutes about three things. The conclusion I reached about the problems in our healthcare system, the sources of those problems, and some ideas for change based on that analysis. Let me warn you, though, in advance that the bills currently before the Congress do not include the ideas that I will put forward. On the other hand, though, I also hasten to add that they're very practical if anybody would take a look. On the other hand, in the discussion period, I'd be happy to talk about these current proposals, as I'm sure my colleagues will as well. The U.S. healthcare system is characterized by a series of paradoxes. One, the U.S. spends more per capita on healthcare by far than any other country, yet 47 million Americans have no health insurance. Some of the most important medical innovations originated here, yet growing numbers of Americans have no access to them. The U.S. has some of the best facilities and best trained doctors in the world, yet quality throughout the system is unreliable. These problems have persisted for decades, yet we have failed to solve them over many years. What caused these paradoxes? In a word, incentives. Everyone, following his own incentives, makes decisions that undermine the system's ability to achieve basic goals. Employers facing higher costs drop insurance or cut it back. Insurers wanting to earn higher profits segment the market to attract favorable enrollees and discourage unfavorable ones, and they introduce payment rules and rates that discourage good care. Individuals also facing higher costs decide to go without insurance or delay seeking care when they need it. Providers of care refuse to treat patients of some payers. They over-provide and under-provide services, in part to cope with these insurance rules and payment rates, and they fail to invest in modernization. Even state and federal governments, which are supposed to provide a safety net, cut eligibility criteria for coverage and reduce payment rates to providers. All these groups tend to take a short-term perspective and make decisions that appear rational for them, but are dysfunctional for the system as a whole. The obvious solution to the paradoxes, so that everyone has access to the care they need, costs are kept under control, and quality becomes more reliable, is to change those incentives. Here's one way to do that would solve the problems the healthcare system faces at modest cost. One, first, require that everyone contribute an income-related amount, that is, more for higher income people than for others, to a dedicated pool of funds to be used to pay insurers and health plans. Then issue vouchers which entitle everyone to choose a health plan or insurance policy that meets federal standards for covered services, appropriate numbers and types of providers, and fiscal and managerial capacity. Third, all the payments would be deposited into a federal health insurance fund. The fund's managers would estimate the next year's needs and set rates to create a pool large enough to cover them. Fourth, private insurers would be paid risk-adjusted amounts so that those that happen to attract large numbers of high-risk people would not be disadvantaged by their success. That is, the health insurance fund would pay the plans more for older people and those with pre-existing conditions than for healthy 25-year-olds. Importantly, individuals would choose a plan based not on price, but on the particular providers who are included and the quality of the plan's service. Another benefit of this proposal is that those who like the coverage they have would be able to select the firm that provides it. Even with these protections, however, fee-for-service payments to providers are likely to promote higher utilization rates and therefore higher expenditures. So the question is, what will the plans do to cope with that? Risk-adjusted payments will provide protection for a while and give firms time to work out other arrangements. Some will find it advantageous to change the incentives under which providers would work. They might transform themselves into prepaid group practices on the model used by the Group Health Cooperative of Puget Sound and other prepaid group practices that we now call HMOs, or contract with provider organizations whose physicians are salaried, like the Mayo Clinic and other distinguished organizations. Both of these models provide high-quality medical care at reasonable rates and have subscribers who are a lot more satisfied with their plans than the typical American is. Those arrangements would not be mandated, but would develop over time naturally through negotiation between insurers and providers when they consider it to be a rational response to changed conditions. To take in more revenue, plans would need to attract more subscribers. To have more net income at the end of the year, they would need to provide good care efficiently. Further, since the entire population would be covered, the possibilities for expanded financial rewards are considerable, but only for plans that attract lots of subscribers and deliver good care efficiently. Since subsidies would be embedded in the progressive tax rates, people with high incomes would pay more, but not as a surtax, as is included in some of the proposals that are now before the Congress. Everyone would need to participate. One, because an insurance pool needs lots of healthy people who contribute to the fund that pays for care used by sick people. Secondly, because everyone has a non-zero probability of using services. In other words, no one can guarantee that he won't need services. Third, because everyone will be able to sign up with a primary care physician and thus have ready access to inexpensive, appropriate care early in an illness episode. Over time, the patient and physician will build a relationship of trust that can improve care in the future. The most important point is that these ideas will make it possible to accomplish the goals of reform at a manageable cost. More people would use services which will increase spending, but savings would result from being able to use the appropriate level of care early in an episode, dramatic reductions in the use of emergency rooms and hospital admissions, illnesses that are kept from escalating, and reduced administrative spending from a much simpler system. Administration would be relatively simple. Everyone would have the same comprehensive coverage. The IRS already knows how to collect taxes based on progressive rates. Insurers already negotiate with providers. Since it would be in the interest of both to do so, they could work together to develop methods for improving efficiency, quality of care, and customer service. Even the health insurance fund's role would be simple. It would determine the next year's financial needs, certify that insurers and health plans offer the mandated services, and have the administrative and financial capacity to receive payments from the health insurance fund, to enroll providers, and to distribute payments to them. The main objections to these ideas are predictable. For some, it will look like too large a role for the federal government. Insurers and providers might resist the need to master new ways of working together. But for the public, not only will health insurance be simpler and more secure, but also care will be more stable and reliable, and the bill will be manageable. If we start by thinking about what we want to accomplish, that is, to cover everyone, to control costs, and to improve the quality of care, this is just about the fairest, simplest, and least costly way to do it. All it takes is a willingness to think outside the box. But rational as it may seem to an academic researcher, here is where politics rears its ugly head. And I should mention that the final part of my book, a third of the book, is devoted to political strategies for accomplishing these ideas. Although incentives produce outcomes that are dysfunctional for many individuals and for the society as a whole, many groups do benefit substantially from the status quo. Among them are not only economic interests, but political interests, including congresspeople who are looking toward the next election. And others have learned to live with these conditions. These groups protect their interests assiduously and make changing those incentives hard. But in conclusion, let me say that if we, as Americans, the distinctive American philosophy is pragmatism, which means we find a problem, we define it, we look for the best way to solve it, and we don't let ideology or extraneous factors interfere with our determination to solve those problems. If we return to those roots, as an optimist, I believe we can really accomplish the goals that we set for ourselves. Thank you.
Thank you, Steve. So we had Steve speak first because he was giving a very comprehensive discussion of the problems. As Randy said, I'm a mathematician, a statistician. I've been working intensively on health policy issues, a lot of them relating to payment and payment reform, since I moved from the mathematics department. Maybe I was a teacher for some of you. A long time ago, I moved from the mathematics department to the medical school in 1984, and have been thinking about these issues of how to pay providers better. And for years I've been saying to my friends, the cocktail party question, well, what do you do? That I work on trying to improve and fix problems with healthcare financing. And everybody jumps and says, oh, you mean you're for single payer? And the first thing that I have to say to people is there really are, and this is a very important thing, and a lot of people who should know better don't separate these two separable problems. How do we collect the money that is needed to have a pool of dollars that will be spent to cover the healthcare needs of the nation? And the second half of the healthcare puzzle is how do we figure out how to spend the money wisely to create the right incentives. So in the 1980s, it was even sort of a running joke in movies that HMOs were terrible entities, and they would just deny you care because that's what their incentives were. They got a chunk of money to take care of you, and the less they spent taking care of you, the more money they made. But I've started looking at the healthcare system before that, and there are different bad incentives that you can have. So I remember a time when some people would go to hospitals and there would be doctors who, when they got someone in the hospital, they would do a test, they would do another test, they would do everything they could think of to extend that hospital stay and to run up the bill. And those doctors were loved by the hospitals because they were such good revenue generators. So you really, really have to think when you're setting up an incentive system how to find a middle way between the Scylla and the Charybdis of paying fee-for-service, in which there's an enormous incentive to do more stuff, whether it's good or not, and paying in a fully capitated way, the way you do with HMOs, in which there's an incentive not to spend any money. And so those of us who work on the second half of the problem, not how to collect the money, but how to spend the money to provide the right incentives, that's what we worry about. So Steve has said it, others have said it before. The reason you're here is that in some sense we all understand that the way we purchase health care in this country it's a broken system. It needs to be fixed. And one of the problems that Randy Ellis and I have been working on for a while is in particular the way that impacts on the delivery of primary care in this country. So how many of you have a primary care doctor? How many of you know somebody who's tried to recently sign up with a primary care doctor and couldn't find one? Quite a few hands, quite a few hands. There's a reason. And the reason is that the way that we have done healthcare in this country, the way we've paid for healthcare in this country, has truly strangled the entire primary care delivery system. It's shut off the entry of new doctors into the system, because who would go to all the trouble of going to medical school and consciously choose a track of practice that earns a half or 1/3 of what any other thing that you could do with your medical degree earns? And in addition, it's not so much fun anymore, because the only way you earn enough money to run your practice is to churn patients through face-to-face visits, because that's what the system pays for. And this is not what primary care doctors of old chose and looked forward to when in the past a lot of people chose to become primary care doctors. And the system has burnout for the doctors, and the patients are unhappy. You probably feel that the last time you saw your primary care doctor, they didn't spend enough time with you. They rushed you through. And there's a reason, and the reason is that we underpay for those visits. We underpay. But not only do we underpay for those visits, but it's the only thing we pay for. We don't pay for prep time. We don't pay for your doctor to meet with a team of people to figure out how to manage your care well. There's all kinds of continuity of care issues that we simply don't pay for. So another thing is a patient goes to the hospital, and typically we've looked at quality in terms of, did everything happen during that hospitalization that should happen for that patient, given why they came to the hospital? But what we haven't known how to do is how to say, did that patient really need to come to the hospital in the first place? Not just were they acutely ill, but could we have avoided their becoming acutely ill? It's very hard in a fee-for-service system to pay for events that don't happen. And yet the truth is, the real value, the real opportunity to save money in the healthcare system is paying for events that don't happen, because you've had good care and you've avoided having those events. So the payment system that we have will not in and of itself change healthcare, but healthcare cannot really change without a radically changed payment system. And so I would say that we can facilitate, we can make possible changes that others are trying to make, would like to make, but really can't, because they're so bound in by the needs that are created by this dysfunctional payment system. And there's plenty of evidence. So this is the one people don't really believe, because it just sounds like it's a bill of goods. But we know that we can have better health care at lower cost. This is true. This is demonstrably true. It happens in most other countries in the world. It happens in isolated places in the United States where doctors have been able to practice as teams, where they take responsibility for a population of patients. So the work that I'm involved in now and really excited about has to do with the patient-centered medical home. It's an attempt to rescue and rejuvenate primary care. The idea would be that a group of clinicians band together, they have a variety of skills, not just an MD, and they take care of a defined panel of patients. And they have the IT capacity to watch what's happening with those patients. And we make a risk-adjusted payment to them. If they're taking care of 5,000 patients who are very, very healthy, they don't need the same resources that they need if they're taking care of 5,000. I said it backwards, right? If they're taking care of 5,000 very sick people, they need a lot more resources than if they're taking care of 5,000 really healthy people. So the project that Randy and I are working on right now in a variety of ways is working with groups of clinicians who have agreed to become patient-centered medical homes in a demonstration project where they will be paid using these risk-adjusted models, using these models which start out and say, there's an amount of money that you need to do a good job. We're not going to tell you how to spend that money. We're not going to tell you what services you have to deliver. We're just going to give you this money, and we're going to tell you, run with it, do a good job. A lot is known about how to do a good job. But we're not going to disappear and say, whatever you do with it, it's yours. We have to come back, and we have to make risk-adjusted judgments about whether there's really been bang for the buck, whether or not this group of patients is healthier than they would have been under the kind of dysfunctional care that people are getting now. And so we make risk-adjusted judgments about what you can expect, about how many emergency room visits there would normally be, and we want to see fewer of them, about how many hospital visits, we want to see fewer of them. We want to see people more functional. We want to see patients answering patient satisfaction surveys who are happier with the access they have, who feel more confident that they understand their illness and how to manage it. So this is the kind of reform that, at least at the demonstration level, is included in the current bill. And we're very excited that if we have the opportunity to demonstrate it, we will be able to propagate a better way of doing healthcare in this country.
Okay, well, I'm going to pick up a bit on what Arlene said about quality of care and incentives, and I'm going to really just confine my remarks to the healthcare reform debate that's going on right now in the U.S. in relation to quality of care. And of course, many of you have read a lot of articles in the newspapers about the healthcare reform debate, and much of it really focuses on expanding health insurance to the many millions of individuals in this country who do not have it and how to pay for it. But also part of the debate is really very much a focus on quality of care. And there's a very good reason for that, and that's because quality of care in this country has really been shown not to be particularly good. There's many examples. I'll give you three. The Institute of Medicine, almost 10 years ago, issued a report indicating that between 50 and 100,000 people in this country each year die in hospitals due to errors, many of them which are medication errors. Another is that the Rand Corporation did a study showing that people in this country only receive appropriate care, that is, care that conforms to the best evidence available, only about half the time. So when you see a healthcare provider, you can pretty much flip a coin, because really only half the time will you receive care that you really should be receiving based on the best available evidence. And three, readmissions. Okay? Medicare patients are readmitted to hospitals 1 out of every 5 times. So 1 out of 5 Medicare patients return to a hospital within 30 days, often because of poor care, poor coordination of care between the hospital and a nursing home, or because they didn't have good discharge planning to begin with. Right? Now, poor quality, as we know, also costs a lot of money because people end up getting more expensive tests and procedures because the care wasn't provided right in the first place. Well, the Senate Finance Committee has issued a healthcare reform plan, and that's the one that most of you are reading about in the newspapers, that offers offers a number of different reforms on healthcare quality, 3 major ones that I'm just going to outline here and just briefly talk about. One is something that's called pay-for-performance or value-based purchasing, which is to begin to link the payment of healthcare providers to the quality of care they receive. This is something that we haven't done in this country. As Arlene alluded, we've been basically paying providers in this country based on volume, how many patients they can churn out. We do not pay them based on the quality of care they receive. And whenever I talk about this, I think about many years ago when my son was very little. He went to a soccer tournament, and he came home, and he dragged this enormous trophy, big ornate trophy. It was bigger than him, through the door. And I looked at him, and I kind of expected he was going to tell me, all these stories about victory and glory. And so I said, "How'd you do?" He said, "Dad, we got killed. We didn't win one game." Well, as some of you may know, there's been this big debate in youth sports about whether we should be keeping score for kids and whether we should be giving them all the same size trophies no matter whether they win or lose. Well, in fact, that is actually what we've been doing in healthcare for a very long time. We don't keep score. We don't keep score of healthcare providers, and we give them all the same size trophies. We pay them all the same, regardless of how well they do. Well, the Senate Finance Committee health reform plan would begin to make changes there. For hospitals, it would begin to adjust hospital payments based on how well they do in terms of quality of care. Okay, they would measure quality, and then they would adjust payments based on how well they do. So that's a start. 2, they have a concept called joint accountability, or the idea of trying to get providers to collaborate with one another. Now, I'm sure many of you have had the experience, you go from one physician to another, you get referred from one specialist to another. You end up getting conflicting advice. No one's really keeping track of information. Who's in charge? You're left confused, concerned. Well, this reform plan would create incentives for providers to work more closely together, to manage conditions like diabetes, asthma, other kinds of chronic conditions. One way it would do it is it would give providers incentives to create this sort of umbrella organization called an accountable care organization, whereby if providers got together and collaborated in certain ways, they would have incentives to provide higher quality at lower cost, and they would receive larger payments as a result of that. All right? So the idea is to create this concept of joint accountability for providers. Otherwise, providers get paid separately, and we can get a provider, multiple providers billing separately for treating the same patient for the same condition. This would begin to make changes to that problem. All right? It would also create the opportunities for what they call episode-based payments, or I should say actually bundled payments, where providers could actually share in the same payment for treating the same patient for the same condition. A third reform consideration that's part of the Senate Finance Committee plan is to try to curb preventable readmissions. So I mentioned before, readmissions is a big problem. 1 out of 5 Medicare patients go back to the hospital within 30 days, often because of poor care. The reform plan would create financial penalties. All right? It would actually penalize hospitals that have been shown to have a track record for preventable hospitalizations. It would track the hospital readmissions. It would look at the quality of care provided. And hospitals that have a track record for getting patients back, okay, within a 30-day period would ultimately in the future be penalized financially. So these are all good things, I think, and this could represent some real progress. I do have just a few concerns that I'll also mention as well. One is that the healthcare reform plan that's been issued by the Senate Finance Committee really takes a fairly incremental approach to the idea of linking payment to quality. It really only focuses on hospitals. There's some anticipation that eventually physicians, skilled nursing homes, home health agencies might also be included, but it really focuses only on hospitals, and we really need to expand that concept to many other types of providers. 2, even for hospitals, there's not a lot of money at stake. It appears to be only maybe 5% of Medicare payments for hospitals would actually be put at risk based on the quality of care they provide. All right? Now, 5%, Medicare represents about 40% of hospital revenue, and so 5% is some real money, but that may not be enough to really make the kinds of changes that we need to see. And then 3, overall, the healthcare reform plan that's been issued by the Senate Finance Committee really doesn't do enough to sort of break the connection that Arlene was alluding to, which is this idea between volume and payment. That healthcare providers get paid for churning out a lot of patients, and also they get paid, of course, when we're sick. They get paid when we need care. There's really no attempt to try to create any incentives for healthcare providers to keep us healthy. You know, many centuries ago in China, village physicians only got paid if they kept the people in the village well. If people got sick, they didn't get paid. That's not a bad concept for us to adopt. I'll stop there.
Great. So I'm going to start with a few questions for our panelists, and then I also want to invite them to possibly ask questions of each other before I turn it over to the audience, since I think they obviously can react equally well to their own comments. I wanted to start with Steve, who had a discussion of suggesting an income-based financing of healthcare with a voucher system for people to be used to purchase an insurance policy of their choosing. I believe that would imply a great deal of redistribution in terms of higher taxes on relatively higher income individuals and lower taxes on lower income workers, as well as some redistribution across ages. Younger people would presumably be paying relatively more than older people for their premiums, since it's an income-based system instead of a fixed premium price that we have today. Do you think that America is ready for this significant amount of redistribution?
Why not? I mean, I think part of the answer to that is, how do you present the question? And if we were to present the question as what we would get for that redistribution, and I don't know how significant the redistribution would be, but that's in your bailiwick. But we know that people have been for more than 20 years. Bob Lendon has been doing surveys of Americans and comparing them to surveys of people in other countries about their satisfaction with their national health systems. We always come out near the bottom. Americans have been dissatisfied in serious ways with our healthcare system for a long, long time. And the situation is getting worse. More and more people are losing coverage, more and more people. One of the groups that I'm most concerned about is the underinsured, and one of the, I think, less positive elements in the Senate Finance Committee proposal is that some of the insurance plans that people would be required to buy would cover only 65% of their health care costs, meaning that they would have to come up with 35%. Now that's redistribution right there. It's a different kind of redistribution. And for a lot of people, it would mean they wouldn't get care. We already know a lot about the underinsured. And this Senate bill, that provision of it, would create a whole lot more of them.
Great. Arlene, I think both you and Gary have advocated changing incentives on the providers, and I've worked with you on that. One of the things that keeps me awake at night, and I think you and Gary could both respond, is this question that even if we change the official incentives paid by the payer or an accountable care organization, so we reverse that, won't the specialists and the hospitals be sitting there ready to offer even bigger incentive payments to keep doing what they've been doing and keep repeating referrals and making sure that they get lots of additional patients to be able to refer? What's going to keep that from happening, say, Arlene?
Good question. My perspective is that there are a lot of people out there who really are not in this business to make the most money they can, that they really go into medicine because they have a service perspective, and that they are doing the best they can to survive in response to a truly crazy system. I I may be stepping outside. I'm certainly stepping outside of my expertise when I interpret the economist Schumpeter. But my interpretation is that he says, as long as the payment system isn't too crazy, as long as it isn't really wrong, if it's approximately right, if you give the people who want to do a good job and create value, if you give them a fighting chance, that will, in fact, be a technology that takes over.
Yeah, I'll just add to that the payment system can't be too crazy, the incentives can't be too crazy, and they also have to be aligned. And that's one of the lessons that I think we can take from the 1990s when we did try to make some changes to payments. Different providers had different incentives, and they, of course, clashed. And one of the things that we really need to do, and this is one of the concerns that I do have with the Senate Finance Reform Plan, is that it focuses on changing incentives to improve quality really on hospitals. We need to do it across the board. We need to have providers all marching, to the same drummer, at least in the sense that they have the incentives to do higher levels of quality and to keep people healthy.
Great. Gary, this question is for you primarily as a legal scholar. I believe that one of the impediments to the care coordination that we all know is desirable is that there are both legal barriers and regulatory barriers and informational barriers whereby hospitals don't want to share their medical records with, say, nurses or mental illness behavioral providers or doctors because they're worried about, this incredibly rich resource, or they're worried about lawsuits that someone will discover a mistake they made. What change in the legal structure or regulations is going to encourage sharing of information that's going to be dangerous to them? Why would they want to start doing this?
Yeah. Well, I mean, there are a number of legal impediments to some of the reforms that are being anticipated now in Congress. There's antitrust, which certainly relates to sharing certain information. There's collaboration. Fraud and abuse laws could certainly get in the way of trying to promote providers to be more collaborative. There's a number of other legal barriers for providers to work together. So legal reforms are part of what's being discussed in the healthcare reform debates. The specific legal reforms that will be needed will, of course, depend on the final details of the healthcare reform plan. But it is true. There are a number of reforms that are being discussed now and have been reduced to paper in the reform plan that actually can't go forward unless there's some changes to the basic legal structures that exist around healthcare organizations and healthcare providers.
Great. And Steve, if I can return, an interesting challenge is that the U.S. already has lots of diverse health plans, group health cooperative, HMOs, PPOs. The side of your model and framework for saving costs is basically relying on innovations and changes in the behavior of those plans so that they result in better quality care. Why do we think that these same insurance companies are suddenly going to figure out how to do it better? I mean, in a sense, they've already have that opportunity. If they were successful, people would be flocking to especially effective HMOs and managed care plans, but that doesn't seem to be the direction right now.
Well, a couple of things. One is we know that HMOs in the prepaid group practice model of Kaiser Permanente and Group Health Cooperative and a few others work. They do provide good quality care at reasonable cost. The reason that insurers, the reason that insurers haven't done that, haven't followed them in that route, is it's been against their incentives. They make a whole lot more money doing it the way they do than that way. And they're in, both Kaiser Permanente and Group Health Cooperative, and I think virtually all the others, are not-for-profit organizations. Most of our insurers now are for-profit companies. Didn't used to be that way, but it is now. And so they have different incentives. One of the things that my proposal would do is change the incentives on the insurance companies, because their income would be fixed, and they would have certain obligations with that income. Their income would be predetermined based on the characteristics of the people they enroll. They would get higher payments for people with pre-existing conditions or for older people than for others, but they would have obligations to provide, this comprehensive range of services to the people they enroll, and they wouldn't be able to, and they would have to enroll anybody who wanted to join. So the only way they could make any money is by finding better ways of delivering care more efficiently. And since, as you point out, there are a lot of models that have already demonstrated it can be done, it's not like reinventing the wheel. It's just that these guys have to figure out that it's in their interest now to do it.
So can I paraphrase? Up until now, the insurance companies have been able to make the most money, and a lot of money, by what we call creaming. That is, making sure that the people they sign up are healthy and denying service. And that way of making money should disappear. And if it disappears, then they're clever people. They'll look, we hope to set up an incentive system which says the place to make money now is to do a better job of giving care.
We didn't have any advocates of a single payer system on the panel tonight, but imagine that I were one, and I might argue, and I'll ask Gary this question, what hope is there to control costs and to change the behavior of providers when we have so many different health plans so that no one of them has bargaining power to either set fees or change an individual doctor, because they can always say, no, I'd rather just take the laxer standards and the higher fees from some other health plan?
Well, in terms of controlling costs, which of course will be a big concern as we expand health insurance, the hope is that we can control costs by providing care more effectively, that we can do a much better job managing chronic care, chronic conditions like diabetes and asthma, which are very, very expensive, that we can do a better job reducing the number of preventable readmissions, which is extremely expensive and costs Medicare billions of dollars. So certainly there's a lot of hope that we can save money, we can control costs by providing better care. As far as having multiple plans, of course, the hope has always been that multiple plans will can actually promote competition that can reduce payments. Obviously, there's debate about the extent to which that actually has been effective, given the rate of healthcare costs over the last 6 or 7 years. I suppose many would say competition hasn't really done what we might have hoped. But aside from that, given the direction that we're currently going with healthcare reform, we're going to have to hope that we can save money, we can control costs by providing care at higher levels of quality and managing chronic conditions much more effectively than we've done in the past.
Mm-hmm. And I do want to, okay,
Can
Steve,
I just
briefly.
Jump in on that? One of the idea behind many of the proposals that are being considered by the Congress is that competition, we have to increase the opportunities for competition among insurers. And that will both bring down costs and improve quality. I think that is a very weak strategy. I think there is virtually no possibility that that will happen if we have, and that's a very strong statement, I realize. And the reason is that insurers have 3 ways to differentiate themselves. One is by changing the availability of their plans. That is, choosing, as Arlene says, segmenting the market and discouraging people from who are going to need services from signing up with them. Secondly, by changing the quality of their coverage, the rules, what services are covered, the rates, the rules of coverage, And the third thing is price. Now, the way they are going to be able to lower price or to keep price down low enough that people can afford these plans is by changing those other two elements, availability and quality. But if the new law takes away a lot of their flexibility in doing those things, in denying, in requiring that they enroll anybody who wants to come, and in specifying what services are covered, then how in the world are they going to keep their prices down? They're not going to be able to do that.
Very quick.
Very quick, and then I do
Very
want to give
quick.
the audience a chance.
So I just wanted to say, single payer would be such a great idea. It would make so much more sense. But what I really want people to understand is that it will not solve all the problems. That there is this second piece that needs to be solved separately. Whether we have a sane, efficient way of collecting the dollars to pay for health care says nothing about whether we have wise ways of spending that money to ensure that we get value in health care.
Great. Well, I'd like to open up the floor to having questions from the audience. If you could try to be brief and be sure you ask a question. I see the first hand is, well, first hand will be in the back and the second will be the blue shirt in the front here. Please.
Keith Batchelder, Genomic Healthcare Strategies. Thanks for an informative talk. I want to point out that you've spent most of your time talking about policy initiatives. And I wonder if there is an opportunity for Adam Smith's invisible hand, and that there are other areas that might actually reform healthcare as we go forward, and get your comments on what you think how they might play out. If Ford Motor Company, $50 billion market cap, the only solvent motor company, made an initiative, I think we'd all pay attention. On the other hand, I can point out that Medco, a pharmacy benefit manager, a $50 billion market cap, is moving into the disease management business. I can also point out that Walmart, a $200 billion market cap company, is moving into the pharmacy business and actually into the IT business for physicians' offices. And Johnson & Johnson, a $150 billion market cap company, is offering Pfizer is offering to only get paid for drugs if they actually work. Do you see those as things that are going to affect healthcare costs in the United States? Are they going to be significant? Do they impact in the way we think about policy?
I'll take a first stab at that. I think the short answer is no. It will not have an impact. It could have an impact in a few small places, but we've tried a whole lot of other things analogous to the ideas that you were just talking about over many years. And while they may have had an impact in a small area for a few people, they've had absolutely no impact on the system as a whole. And as I was suggesting, I think competition is the wrong model in health insurance and in health care. I mean, Kenneth Arrow wrote about this 40 years ago, and we seem to have ignored and I'm not an economist either, but we seem to have ignored the lessons that he taught us way back then. And the example I just gave about insurance companies, as I say, they have only 3 ways to differentiate themselves, and 2 of those ways are not good for us. So I really don't see competition playing the same role in the healthcare or health insurance field as it does in high tech or in computers or in in a lot of other areas.
So Steve said there's one word here, incentives. And I would like to say that the market is a marvelous, marvelous instrument. But you get what actually you may not have predicted you were going to get, but what certainly in retrospect is exactly what you set up to get. So if these urgent care clinics are set up all over the place, it's because the way we pay for the kinds of services there, a profit can be made. It's not necessarily because it's good for the system. If we had a really rational way of paying, then big companies trying to make money based on this rational way of paying, perhaps they could do something good. But with an irrational way of paying, they will figure out how to make money in this dysfunctional payment system, and it will not be good for the country.
Yeah, I'll add to that. I certainly agree with the idea of rational payments. So you made the point about Pfizer and only being paid for drugs that work. Well, I think that's an important point. Now, that's not going to solve the whole problem, but we have seen, over the last 20 years, a proliferation of drugs and technologies. Some of those drugs and technologies are life-saving, and many of them are not. And we haven't really developed a good system in this country for really assessing the effectiveness of these drugs and technologies so that they really have value when we introduce them into the system. And one of the reform considerations right now is to actually require drugs to undergo what's known as comparative effectiveness, where we don't compare a drug to a placebo, which is right now all that the FDA does, but actually we would have to compare a pharmaceutical company would have to compare a new drug that it wants to introduce to other drugs that are already available in the market and to demonstrate that it has superior value relative to those drugs. And I think that could be a positive development and could help to control costs.
Yes, I think we could have our next question.
Hi, thank you, panel, for coming this evening. I have a question for you. I understand that the main focus is on the folks who are uninsured in this country, but I look at things in a little different perspective. My husband and I are small business owners. We have insurance, and I don't even want to tell you how much we pay to have that medical insurance. The costs keep going up, up for us. And I'm wondering, it's kind of like the Wizard of Oz asking the wizard, is there anything in that little black bag for us, the small business owner who keeps getting higher and higher costs? Do you see anything for costs to become a little more reasonable for people who already pay for insurance?
I think I can answer that as an economist in that I've looked at the proposed legislation, and actually there's a lot of attention spent on the small group market, the 1 to 100 or 2 to 100 employee size. And just as they're setting up, this is a controversy, but they are likely to set up some cooperative or an available system for people to buy insurance that would support individuals as well as small businesses. In Massachusetts, we have the Health Connector, which for many people has resulted in an enormous reduction in the premiums they pay for being able to buy insurance.
We're part of the SBSB, so we already have, we're already part of the Small Business Association to get better health costs. But still, it just seems to be, every year it just keeps going up. It's like $300, $400, $500 every single year.
Yeah. It's absolutely a challenge. The rate of increase of premiums is mind-boggling, and unfortunately they've just announced in Massachusetts the averages are again going to go up numbers like 10% or so, so it's a very
So they signed up all those extra people, but they don't have primary care doctors to take care of them. So we can't keep the costs down. But, fundamentally, we have to learn how to do this better. And if we do learn how to do this better, and if you are allowed to pool your premiums with others, those premiums should stop going up that fast.
I think I'm sorry, Randy. I think if there's one comment, one thought to take away from what all three of us are saying, it's that all these problems are interconnected. And we really do have a system here in the sense that you squeeze one part of the balloon and another part pops out. We can't solve your problem of rising premiums, really solve it, unless we deal with the incentives that under which providers are paid, and unless that in turn leads to changes in the way care is organized, and we have more primary care we focus more on primary care, and we have more coordinated care, and so on and so forth. It really illustrates, your question really illustrates why it's so important to solve all of these problems together.
If we could turn, I see the person in the blue shirt has a mic.
Hi, thank you for coming. I appreciate the conversation. I'm curious why none of you have discussed the money that's available under the stimulus program. The government has already set aside $42 billion to do regional health exchanges, healthcare effectiveness research, electronic health records, which don't even start to get paid for until the end of next year, as means of becoming more efficient, and why we wouldn't focus on becoming more efficient before extending care and making the problem worse.
Anyone want to take that on? I will just comment that from what I see, most of the provisions of this legislation would not take effect until 2013, so we're already talking 4 years from now. A lot of this stimulation is of some basic research, some demonstrations. They take quite a while to be able to generate results that can be implemented.
The vast majority of the program, though, is electronic health records. That's $36 billion, and that's through 2015 from an implementation perspective.
I actually am not an expert on how successful that will be. I am impressed by the magnitudes of money they're throwing at the problem, and I hope that it is successful and as one would like. I'm not sure that, I just don't know.
It's not clear that it is more expensive to have everybody in the system than to have people out of the system. It's truly not clear.
But it's also not clear that adding people will make it more efficient.
Well, actually, there are reasons to believe that adding more people will make it more efficient.
Yeah, and if you look at the Senate Finance Reform Plan, there's quite a bit in there about making the system more efficient as well. So, to the extent to which they're connected, we can debate. We could also just see them as separate objectives. Certainly, as a major policy objective right now, the idea is to expand health insurance. But at the same time, the reform proposals that are coming out of Congress also have a very substantial focus on improving quality and improving efficiency as well. We could certainly discuss whether they're in the right order, or maybe we should have worked on the efficiency consideration before we expanded insurance. But at this point, the reform plans are trying to address both objectives at the same time.
For example, we know that the people who arrive at the Medicare program at age 65, having previously been uninsured, are far more expensive for the Medicare program than the people who had insurance earlier. It really is squeeze it down here, pops up there, and it's truly not clear that, aside from the fact that some of us feel that it's really a moral imperative, that it's just a shame in this country that we have a large fraction of our population that doesn't have access to health care, that we have that half the bankruptcies in this country are medical bankruptcies, that we just simply have to fix it because we have to fix it. Aside from that, there's every reason to think that it will be economically wise.
Very good. In the back? Mm-hmm.
Yes, notwithstanding Steve's skepticism about the value of competition among insurance companies, there are people that believe that if insurance companies were allowed to compete against each other, and in fact this is one of the justifications for the public option, is that it creates competition for the insurance companies. What is the impediment to allowing insurance companies to compete across state lines and to be able to offer their plans across state lines? I've never understood the impediment and the argument against it. What is the argument that disfavors that?
Yeah, probably tradition mostly. But the idea is it's always been regulated at the state level, and we haven't had a federal regulatory structure to take on health insurance. But I agree with you that could do a lot to promote competition. Also, we need to keep in mind that over the last decade, health insurance companies have been allowed to consolidate in a very, very substantial way. And in fact, in many parts of this country, there's very little competition. around health insurance. In many states, you have a health insurance company that has about 85% of the market share. So we really haven't given, I would suggest that we really haven't given competition fair opportunity to really make a difference in health care. And that goes back to a point that I made earlier about antitrust and regulating competition. We will certainly need or likely need to make some changes in the antitrust laws to deal with some of the reform initiatives that may come out of Congress. At the same time, there may need to be more aggressive enforcement of antitrust laws in certain areas that we've kind of ignored. And actually, the Obama administration is really planning to ramp up antitrust enforcement in the healthcare industry, and I think that the insurance sector will certainly be one of its primary targets.
Gary, let me ask you a question. If we say that health insurance companies have to accept all comers, and if we say that there's a basic benefit that they must provide, what is it that one insurance company could do to differentiate itself from another insurance company that would add value? In what sense could we hope to have healthy market competition that would create something more valuable?
Well, there may be a minimum benefit package that they would all have to be required, but at the same time, they may be able to add certain types of benefit packages that would go beyond the standard package. Also, there's service. One Starbucks is across from another Starbucks. People seem to have choices over which one they want to go to, even though they're both across the street. People seem to have their favorites. So I think that there are ways that they can differentiate themselves by offering perhaps enhanced benefit packages, by offering better service to their customers, and competition could still have some opportunity to control prices.
I'm afraid we have time for only one more question. Well. Oh, if you could give a very short response, yes?
Yeah, I'm just not sure that was a response to my question. My question was, it would seem like that's an easy one, that both sides could agree that more competition can't hurt. So what is the impediment? What is the political argument against allowing that? That's what I don't get.
Well, I would argue with your premise. I think it can hurt. I think we've had competition, or we've had the opportunity for competition for a long time among insurance companies, and look what it's gotten us. And I think Arlene's question is exactly right. If we take away much of the two prongs that the insurance companies can differentiate themselves on, the who's covered and what they're covered for, and the rules under which they're covered, what else can they do to improve value? My colleague Jim Post has studied the insurance industry, and it's not just it's not just health insurance, it's insurance in general. That's what insurers can do. That's how they can differentiate themselves. And the question I think we ought to ask the insurers is, what are you going to do if we have more competition? What are you going to do to improve value for the population?
But I did hear one other aspect of this, and I have to agree. If those who think that we need multiple insurance companies because that will produce competition and it's healthy, how they can argue that and say, and there shouldn't be a public option because they'd run us out of business, that's a hard one to swallow. That's a hard one to see how it's logically coherent.
We have time for only one more question, and I know this woman has had her hand up and been eager, so I'm going to call on her for our last question.
Thank you. I just wondered we're insured with we're at Harvard Vanguard with Tufts Tufts Medicare Preferred, and are very happy with it. But recently they have started up in with shared medical appointments. I just wondered what your comments are on those. In other words, that's for people that don't know, it means the doctor spends an hour and a half or 2 hours seeing maybe 8 or 10 people all at the same time.
Do you like it?
Yes and no. When it was my turn, I wanted more personal attention. But when I was with my husband, and we watched some of the other people's MRIs, and so looked at some of the other MRIs and so forth, I got a much better perspective of what was going on with him. I also felt that I was too healthy for the group that I was in.
I know at Boston Medical Center, there's been some very successful programs of group appointments for people with diabetes. And you bring in people with a common problem, and they can discuss their issues, and they can share tips, and they can bring it. They often do this for people from a certain cultural background, like they might have a Haitian group, and they bring in a chef who might know something about how to make foods that would appeal to that group and teach it together. It's actually one of those exciting innovations that I think would flourish if we had a different payment system.
Well, very good. On the original program, I had a few minutes to try to sum up. I think we've had a very wide-ranging discussion. I was pleased to see so many hands up because it means you're all asking good questions. We certainly didn't solve the healthcare reform puzzle. I think that, I was going to ask each of the participants a very simple question, which we are all wondering, is, do we think that a healthcare reform bill will pass before Obama finishes his first term? So that was the question. If you have a yes or no answer, this is a binary outcome. What is your best guess there, each of our experts?
I would say yes.
Yes.
Yeah, I would say yes. It will have to be done in the next 6 months to a year if it's going to be done at all. But yeah.
Well, I gave them the rest of the term because it could be they fight it out for a long time, but I happen to agree with them that it will happen sometime soon. So there is hope that something will happen. Now, how much we will like it is perhaps a good topic for a future debate and discussion we might have.